Redo TAV encompasses multiple valve combinations with different neoskirt height. In some patients, redo TAV carries a risk of coronary obstruction due to sinus sequestration, which can have dramatic consequences. Therefore, coronary protection strategies have been developed to prevent sinus sequestration. This video will discuss chimney stenting. Chimney stenting consists in the implantation of coronary stents protruding in the aorta to preserve coronary perfusion. Due to the presence of TAV frame, redo-TAV poses specific challenges for chimney stenting that might jeopardize the results of the procedure. Particularly, four factors might affect feasibility, efficacy, and coronary reaccess after chimney stenting: TAV1 design and alignment, TAV2 design, and implant depth. Chimney stenting requires coronary cannulation and stent delivery through TAV1 frame, which is affected by the size of TAV1 accessible cell and commissural alignment. Furthermore, interaction between TAV1 and TAV2 frames might compromise chimney stents after deployment. Different TAV-in-TAV combinations create different danger zones. In case of short TAV1, the danger zone is fixed and determined by TAV1 frame. On the other hand, with tall TAV1, the danger zone is determined by TAV2 design and might change according to TAV2 implant depth in short in tall combinations. These examples show how different types of interactions between chimney stents and TAV frame might compromise the efficacy of the procedure and coronary reaccess. Stent distortion is greater in case of TAV1 with narrow cell design. Furthermore, the degree of interaction is affected by TAV1 commissural misalignment. Based on these considerations, the most favorable scenario for chimney stenting is represented by low implant of a short TAV2 in a tall TAV1 with large cell design and commissural alignment. These are some tips and tricks to perform an effective chimney stenting in redo TAV with short in tall TAV. First, use guide catheter extension to avoid interaction with TAV1 frame when delivering the stents. Then select stents with high radial strength to reduce the risk of distortion. Position the stent inflow above TAV2 frame and keep stent balloon in place after deployment in order to be able to re-inflate during or after TAV2 implant. Then, re-engage the coronaries by advancing the guide catheter extension over the stent balloon to ensure selective re-engagement. Ideally, perform intravascular imaging to assess stent expansion and eventually correct and optimize the stent results. When dealing with coronary access after redo TAV with chimney stenting, these tips and tricks might be useful. First, select a guiding catheter that allows approaching chimney stent from above. Then carefully align the guide catheter to chimney stenting, eventually using a 0035 guide wire to modify guide catheter curve. Use the fishing wire technique to access chimney stent and advance with the loop inside the coronary artery. Use a guide catheter extension with a balloon to engage the coronary artery through the chimney stent. Use a guide catheter extension to deliver equipment, and consider dilatation of chimney stent in order to facilitate equipment delivery. In conclusion, chimney stenting poses challenges in the setting of redo TAV due to the presence of TAV frame, and the following factors affect the feasibility, efficacy, and coronary reaccess after redo TAV with chimney stenting: TAV1 design, TAV1 commissural misalignment, TAV2 design, TAV2 implant depth for short in tall TAV. Chimney stenting for either TAV requires careful patient selection and specific techniques to ensure optimal result and future coronary access.